Welcome to the deep dive. Imagine you're grappling with, persistent shoulder pain or weakness. In today's world, the first step often involves a quick search online, doesn't it? Leading down a rabbit hole of potential diagnoses, followed perhaps by an easy-to-access scan. You might even arrive at the clinic with a pretty firm idea of what's wrong based purely on something you saw on a screen. But here's where it gets really interesting and, well, complex. Our source material for this deep dive makes a powerful case that this modern landscape, all this readily available information and imaging, coupled with a demand for instant, simple answers, has actually made accurate diagnoses harder.
That's right.
It often leads to patients focusing on a scan finding, perhaps a tier that might not even be the main source of their functional problems.
Exactly. The thing that's actually stopping them doing what they need to do.
So, to cut through that noise, our sources champion a different path. A return to what they call a common sense-based clinical practice.
Which sounds simple, but isn't always easy in practice.
They advocate for what they call a cluster approach, one that understands that no single piece of information holds all the answers. Instead, it intelligently combines insights from multiple sources. And who better to guide us through this intricate process than an expert who has dedicated years to synthesizing diagnostic knowledge and skills across generations. Thank you for joining us for this deep dive.
It's a pleasure, and it's a crucial topic, precisely because the pressures of modern practice can, inadvertently push us towards over-reliance on isolated data points. True diagnosis is a synthesis, not just a simple checklist.
That idea of synthesis seems absolutely key. The source material lays this out with remarkable clarity, stating that an accurate diagnosis is the foundation of good medical practice. That feels incredibly fundamental, almost stating the obvious, really, but the emphasis suggests it's a point often overlooked or perhaps, undermined in practice. Why, according to this text, is getting the diagnosis right so absolutely critical?
Well, it sounds self-evident, doesn't it? But the source highlights it because the entire subsequent pathway of care hinges on that initial diagnostic step.
Everything follows from that.
Exactly. All treatment interventions, every therapy, every surgical plan, they're all predicated on the diagnosis. If that foundation is shaky, or worse, incorrect, the entire treatment strategy is likely to be suboptimal, potentially ineffective, or even harmful.
It's the ultimate domino effect, isn't it? Get the first step wrong and everything that follows can go awry.
Precisely. And the source introduces a really insightful way to look at diagnosis by framing it from two perspectives. You have the patient's view. They arrive because they've experienced an alteration in their functional capability.
Right. What they can no longer do.
Exactly. They can't sleep due to pain. They can't lift something they used to. They feel a disturbing instability. Their concern is how the problem affects their life and function.
Makes sense.
Then there's the doctor's view, which perhaps historically has focused more on identifying a particular alteration of anatomy. Is the rotator cuff torn? Is there arthritis? Is the labrum detached?
The what rather than the so what?
Sort of, yes. An effective diagnosis, as defined in the source, is that body of information collected through the process of evaluating the patient's health problem, that determines the content and timing of the treatment of the health problem. It's the synthesis of data that directly informs the functional problem the patient is experiencing, bridging that gap between an anatomical finding and their lived experience.
That distinction makes so much sense. It's about understanding the patient's experience of the problem, not just pointing to a picture on a scan.
Exactly. And the consequences of failing to achieve that effective, accurate diagnosis are significant. The source outlines the potential harms quite starkly. You can prevent or delay appropriate treatment, which means the patient isn't getting the help they need when they need it.
Which is terrible for them.
Of course. Conversely, you can lead to inappropriate or completely unnecessary treatment, exposing the patient to risks without benefit.
And cost, presumably.
Absolutely.
Ah.
Both scenarios increase medical expenditures and waste valuable healthcare resources.
So an inaccurate diagnosis isn't just a clinical error. It has these broad implications for the healthcare system and, crucially, the patient's well-being and finances.
Without a doubt. And the source makes a really interesting point about where the focus has traditionally been in healthcare. It contrasts the effort put into improving outcomes, the value on the back end, if you like, refining surgical techniques, optimizing rehabilitation.
And getting better at fixing things.
Yes, with the effort dedicated to improving the diagnostic process itself, the value on the front end. Historically, less formal effort and perhaps less rigorous methodology have been applied to standardizing and enhancing the diagnostic stage, despite its foundational importance.
Really? That's surprising.
Well, it's perhaps easier to measure surgical outcomes than diagnostic accuracy sometimes. This cluster approach, the source suggests, is presented as a way to bring that necessary rigor to the front end.
That's a powerful observation. It highlights a potential blind spot in how we approach healthcare improvement. So this framework is aiming to elevate the diagnostic process itself.
It is, and the source draws inspiration from a general model of the diagnostic process proposed by Bello and colleagues in the Institute of Medicine, or IOM, report on diagnostic error. They view this as a robust framework that translates very effectively to the complexities of orthopedics and specifically shoulder surgery.
Okay, let's unpack this. How does this general model play out in the specific context of diagnosing shoulder conditions? What does that framework actually look like in practice?
Well, the model is inherently sequential. It begins, as we discussed, with the patient initiating the process because they are experiencing an alteration in their functional status.
The reason they came in.
Exactly. For the shoulder, the source structures this around the three primary presenting symptoms: pain, weakness, and instability. These are the main reasons someone seeks help.
The starting point for the whole journey.
Precisely. And the model then moves into the critical phase of comprehensive information gathering. This is where the cluster approach truly takes root. The source proposes building the diagnostic process upon four key pillars. Think of them as the core data streams you need to collect.
Okay, 4 pillars.
These are the clinical history, the physical examination, special tests, and investigations, which, in the context of shoulder diagnosis, primarily means various forms of radiology, scans.
So it's not about choosing one of those pillars and running with it, like jumping straight to an MRI.
Absolutely not. That's a key message. The fundamental principle of the cluster approach and this framework is that these pillars must be used in conjunction. Information from one pillar informs and guides the inquiry from the others.
They feed into each other.
Exactly. They are meant to be synthesized, not treated in isolation. The source also acknowledges two supporting layers of information: patient-determined factors and expectations, things like their level of apprehension, their concerns about returning to a specific job or sport.
The personal context.
Yes, and occasionally information gleaned during surgical procedures, such as insights gained from direct visualization during arthroscopy.
That's interesting. So even the surgical findings can refine or confirm the diagnostic picture you built beforehand, almost like the final piece of the puzzle sometimes.
Exactly. The process is iterative, even if presented sequentially. And critically, the source underscores that this comprehensive evaluation process then leads directly to determining the content and timing of the treatment. There's a linear, almost cause and effect relationship posited, where the efficacy of the treatment is shown to be dependent on the depth and accuracy of the diagnosis derived from combining all these pieces of information.
It brings it back to that core principle. The quality of the diagnosis dictates the potential success of the treatment.
Precisely. It is the essential prerequisite.
Let's dive into those pillars then, starting with clinical history. The source makes a very strong assertion here, saying a focused history is frequently the most important pillar leading to a diagnosis. That's quite a statement, isn't it? Ranking it even above scans or physical tests. Why is history given such a prominent position?
Well, the history is foundational because it provides the essential context for everything that follows. It's where the patient tells their story, their age, the mechanism of injury if there was trauma, the onset of symptoms, was it sudden or did it come on gradually, and most importantly, the nature of their chief complaints: pain, weakness, instability, or stiffness.
The real-world problem.
Yes. These details are not just data points. They are the roadmap that directs the rest of your diagnostic inquiry.
It focuses your attention from the very beginning, narrows things down.
Exactly. Take pain, for instance. Simply knowing someone has shoulder pain isn't enough, is it? The history needs to capture its localization. Is it anterior, posterior, diffuse? Does it radiate, perhaps down the arm or into the forearm? What is its character? A sharp, intense pain or a dull ache?
All those nuances.
Crucial nuances. What specific movements, activities, or positions make it worse or better? The source even notes that symptoms like pins and needles could potentially be associated with subacromial impingement. Although that's not a primary finding, it adds another layer of detail to consider.
Those specific pain characteristics can really start pointing you in a particular direction, can't they?
They absolutely can. Or if the chief complaint is weakness, the history needs to differentiate between a general feeling of fatigue versus specific difficulty with certain movements or muscle groups. Is there any family history of neurological or muscular disease that might predispose them? That's important too.
And instability sounds like it needs a very detailed history as well.
It does. Very much so. If a patient reports instability, the history of the initial traumatic event is paramount. How did it happen? In which direction did the shoulder dislocate? How was it managed? Did it go back in on its own? Or did it need help in A&E? Getting the full story of that event. Yes. Then you need to clarify what the patient actually means by instability. Do they feel a general looseness, a sense of slipping or subluxation, or frank dislocations where the joint comes completely out? The source notes that a progressive reduction in the energy needed for recurrent dislocations is a significant historical clue, implying worsening pathology.
So it takes less and less to make it happen again.
Exactly. Details like the number of dislocations and the cumulative time the shoulder has been dislocated are also vital, as they strongly influence the likelihood of associated bony damage, which we'll get to later when we talk about imaging.
So the patient's lived experience and their description, even if it's not perfectly clinical language, provide essential clues.
Absolutely. You're translating their experience into potential clinical issues. And for stiffness, the history helps differentiate what they feel from what might be a true mechanical restriction. Is it pain that stops movement, or does it feel physically blocked?
Setting the stage for the exam.
Yes, this sets the stage for the physical exam to differentiate true stiffness, where both active and passive motion are limited with a firm endpoint, from apparent stiffness due to pain or weakness. The source mentions the patient's historical description of limitation in the context of pseudoparalysis, seen with a large rotator cuff tear, which might be perceived as stiffness but is actually profound weakness.
It's like being a detective, isn't it? Piecing together the story clue by clue.
Precisely. And it goes beyond the immediate shoulder issue. A full medical history is indispensable. Comorbidities like diabetes, thyroid disorders, or Parkinson's disease, medications, allergies, previous surgeries, or anesthetics. These can all significantly influence the likelihood of certain shoulder conditions and impact potential treatment strategies.
You mentioned specific conditions being associated with others. Can you give us some examples from the source that highlight the power of that part of the history?
Absolutely. The source highlights some strong associations. Adhesive capsulitis, or frozen shoulder as it's commonly known, is notably more prevalent in patients with diabetes. The risk can be up to 10 times higher than in the general population, and often presents bilaterally in diabetics.
10 times. Wow.
That's a very strong link. It's also associated with thyroid disorders and Parkinson's disease. Rotator cuff tears are more commonly seen in individuals with obesity. A BMI over 30 significantly increases the odds, and over 35 increases them even further.
That's interesting, the link with BMI.
It is. And glenohumeral joint arthritis is more likely if there's a history of previous dislocation in individuals over 70, or if they have concurrent knee osteoarthritis.
That's fascinating. Conditions that seem, quite unrelated can dramatically increase the probability of a specific shoulder issue. The history is building that initial likelihood, that sort of pretest probability.
It is. It establishes your pretest probability, exactly. The source gives an excellent case example for suprascapular nerve entrapment that shows how history points the way. A 32-year-old Olympic volleyball player presenting with weakness in their dominant shoulder, a general ache, and a subjective feeling of muscle mass loss at the back of the shoulder.
Very specific context there.
Very. That constellation of symptoms, in the context of an overhead athlete, immediately raises suspicion for specific nerve issues. The source notes that typical historical findings can include vague, posterior shoulder pain, pain or weakness that varies depending on the position, related to where the nerve is compressed maybe, and the perception of atrophy in the posterior shoulder muscles, the supraspinatus and infraspinatus, or potentially isolated infraspinatus if the compression is further down at the sphenoglenoid notch.
That combination of patient demographics, activity level, and specific symptoms is so powerful from history alone. Really paints a picture.
It's incredibly powerful. It's the essential first step that directs the entire subsequent examination and investigation.
Which leads us neatly into Pillar 2, the conventional examination. Once you've got that rich history, what are you looking for in the physical exam to either confirm or, I suppose, challenge your initial suspicions?
Well, the physical examination is where you gather objective data to complement the subjective information from the history. It involves assessing active and passive range of motion, testing the strength of the rotator cuff muscles, and performing specific provocative tests to reproduce the patient's symptoms or identify specific deficits.
Hands-on assessment.
Yes, it starts with simply looking and feeling visual inspection and palpation. You look for things like muscle wasting, particularly in the supraspinatus or infraspinatus fossa, which is a visual clue strongly suggestive of the significant rotator cuff tear and atrophy.
You can actually see the difference sometimes.
Oh yes, quite clearly in some cases. You palpate for tenderness over specific structures, like the bicipital groove, which can indicate pathology of the long head of the biceps tendon, something often easier to identify in older patients where the tendon is more prominent if ruptured, perhaps.
Yeah.
You also feel for crepitus, that grinding or crackling sensation, which can point towards glenohumeral joint arthritis, but can also be present in subacromial impingement or with rotator cuff tears.
So what you see and feel is adding layers to the history, starting to build that objective picture.
Exactly. Range of motion assessment is critical. Observing a painful arc of abduction, typically occurring between 60 and 120 degrees, is a classic finding suggestive of subacromial impingement.
The painful bit in the middle of the movement.
That's the one. More fundamentally, assessing both active and passive ROM is key to differentiating true stiffness, as seen in conditions like frozen shoulder or advanced arthritis, where both active effort and external force are limited, often with a firm end feel.
A real block.
Yes, a mechanical block. Differentiating that from apparent stiffness, where the patient can't actively move the arm through the full range, perhaps due to pain, but you or the examiner can move it passively. The source highlights the importance of recognizing the contribution of scapulothoracic movement of the shoulder blade on the chest wall, which can give the appearance of normal shoulder elevation in cases of severe glenohumeral joint stiffness, like in adhesive capsulitis, where the true shoulder joint movement is actually minimal.
So they're compensating with their shoulder blade.
They are. This distinction between active and passive ROM is vital for diagnosing stiffness versus weakness.
That makes sense. Active motion tells you about muscle power and pain inhibition, while passive motion tells you about the joint's mechanical freedom.
Precisely.
Yeah.
And there are other specific visual findings you look for. Asymmetry of the shoulder contour can indicate instability of the AC joint, the acromioclavicular joint, and you might see a specific step-off sign in more severe AC joint injuries, type 3 to 6.
Like a visible bump.
Yes, where the clavicle sits high. A dropped nipple sign, where the nipple appears lower on the affected side, is a significant clue pointing towards a pectoralis major rupture. Scapular winging suggests weakness of the serratus anterior muscle, often due to nerve dysfunction. The source also notes that muscle hypertrophy in the dominant extremity is common in overhead throwers as an adaptation. But importantly, it's not characteristic of internal impingement. Conversely, a protracted scapula, sitting forward on the chest wall, might suggest posterior capsular tightness, which can predispose an individual to internal impingement.
Wow, the physical exam is packed with specific visual and tactile clues. Lots to look for.
It truly is. It takes the initial suspects identified in the history and allows you to gather objective evidence. But again, as the source emphasizes, it's only the second pillar. It needs the others to build a complete picture.
Which brings us to pillar 3, special tests. These are specific maneuvers used during the exam, but the source seems quite cautious about their value in isolation. Is that fair?
Yes. That caution is one of the key takeaways from the source regarding special tests. It states up front that these tests are unlikely to be 100% accurate. They're not definitive yes or no answers on their own.
Not a magic bullet.
Definitely not. The source explains the metrics used to describe their performance. Sensitivity, which tells you how good a test is at identifying everyone who has the condition. So if it's negative, it's good at ruling it out. Think snout.
Snout sensitive, negative rules out.
That's it. And specificity, which tells you how good it is at correctly identifying those who don't have the condition. So if it's positive, it's good at ruling it in the think spin.
Spin specific positive rules in hint. Got it. Those mnemonics are helpful for remembering which is which.
They are. But as the source points out, very few individual tests possess both high sensitivity and high specificity. They're often good one or the other, but rarely both.
A trade-off.
Exactly. This is why the concept of likelihood ratios, or LRs, is important. LRs describe how much a positive test result, plus LR, or a negative test result, dash LR, changes the probability of a person having the condition after the test compared to before. A plus LR greater than 10 and a national LR close to 0, say below 0.1, indicate a test that significantly shifts your probability, makes a real difference to your thinking.
So it's about how much the test result changes your initial suspicion based on the history and general exam. Moving the needle, so to speak.
Precisely. You start with a pretest probability based on your first two pillars, and the special test helps refine that to a post-test probability. But And this is crucial. The source is quite critical of the quality of the published literature supporting many special tests.
Oh, really?
Yes. It warns that studies using less rigorous methodology can lead to premature adoption of tests that aren't as reliable as initially thought. They mention specific quality assessment tools for diagnostic studies, like QUADAS and Quarrel, and point to systematic reviews, such as those by Hedges and colleagues in 2008 and 2012, which found surprisingly limited high-quality evidence to support the diagnostic accuracy of many commonly used individual shoulder tests.
That's a crucial point for anyone relying on these tests. The evidence isn't always rock solid for every single one when used in isolation. You need to be discerning.
It absolutely is.
Right.
But this critique of individual tests leads directly to the power of the diagnostic cluster approach using special tests, which the source says is gathering momentum.
Ah, back to the cluster idea.
Yes. The key insight here is that while single tests might be unreliable, combining several tests that assess different aspects of a potential problem, especially when guided by the history and physical exam, significantly improves the post-test probability. The combined picture is much stronger than the sum of its individual, potentially weak parts.
Okay, let's look at some specific examples of tests and clusters mentioned in the source and what value they add when used correctly within this framework. Maybe start with the rotator cuff.
Right. For evaluating rotator cuff tears, the source mentions tests like the external rotation lag sign and the drop arm test as potentially valuable for ruling in a tear when positive. Good specificity.
So if they're positive, it's quite likely there's a tear.
Generally, yes. For the subscapularis muscle specifically, the belly press test and the bear hug test are noted as valuable for ruling in a defect when positive again, high spin. Other tests like Gerber's liftoff test and the internal rotation lag sign are also part of the assessment for subscapularis.
Are there specific clusters for rotator cuff issues that combine these or other factors? That seems to be the key.
Yes, the source highlights a powerful diagnostic cluster for full-thickness rotator cuff tears. It combines simple factors from the history and physical exam: age over 60, presence of a painful arc on range of motion testing, positive drop test, and positive infraspinatus tests like weakness or lag.
So a combination of age, movement, and specific muscle tests.
Exactly. This cluster had a very strong positive likelihood ratio of 28 and a very low negative LR of 0.09 in one study cited, indicating it significantly shifts the probability towards or away from a full-thickness tear.
Those numbers really underscore the power of combination, don't they? What about diagnosing labral tears, like SLAP lesions? That seems like a tricky area to diagnose.
It certainly can be. The source mentions tests like the Kim and Jerk tests for detecting posterior labral pathology. For SLAP tears, that superior labrum anterior to posterior tests, like the biceps load 2 test, were initially promising, but the source cautions about the difficulty in replicating those results reliably in later studies.
So initial enthusiasm maybe wasn't fully borne out.
Perhaps. The Hedges 2012 review, which looked systematically at the evidence, found that the relocation test had the best reported sensitivity for SLAP tears, meaning it was okay at picking up cases, maybe around 70–80%, but not perfect, while Jurgensen's test had the best reported specificity, meaning if it's positive, it's quite likely to be a SLAP tear, but it misses many cases. The passive distraction test, with a reported specificity of 0.85 and a plus LR over 5, is also mentioned as potentially useful for ruling in a SLP tear when positive. The source also clarifies the difference between O'Brien's test, which is an active test sometimes used for SLAP tears, and the coracoid impingement test, which is passive.
So even within special tests for one area like the labrum, the utility varies quite a bit, and you need to interpret them cautiously, preferably as part of a bigger picture, a cluster.
Precisely. That caution is key. For instability, particularly anterior instability, often seen after a dislocation, the apprehension, relocation, and anterior release test are considered important diagnostic tools, especially if they reproduce the patient's feeling of apprehension that sense the shoulder might pop out.
The patient's own feeling is key there.
Very much so. The source highlights a powerful cluster here, combining a positive apprehension test with relief upon the relocation test, where the examiner pushes the humeral head back, results in a very high plus LR of nearly 40 and a low ALR of 0.19.
Wow, that's a strong combination.
Extremely indicative of traumatic anterior instability. The anterior drawer test is also used to assess and grade the amount of laxity or looseness.
How about impingement syndromes? Subacromial impingement is a common one.
Yes, for subacromial impingement, commonly used tests like Neer's test and Hawkins test are mentioned. The Hedges 2012 review reported sensitivities around 0.7 to 0.8 and specificities around 0.6 again, Useful, but not definitive on their own.
So, okay, but not great in isolation.
Correct. However, the source presents a strong diagnostic cluster for subacromial impingement, combine the Hawkins test, infraspinatus muscle test, testing strength, and the painful arc sign we mentioned earlier. If all three are positive, the reported likelihood of subacromial impingement was 95.5% in the cited study.
95%. That's impressive.
It is. It drops only slightly to 91% if two were positive. This really shows how combining these findings from history and exam makes the diagnosis much more probable. For internal impingement, which affects overhead athletes differently, the relocation test and the posterior impingement sign are key tests, specifically if they reproduce the patient's deep posterior shoulder pain.
So the location of the pain during the test is critical.
Absolutely.
And AC joint pathology, that's another common source of pain, isn't it? Up near the collarbone.
It is, yes. Tests like the active compression test, cross-body adduction, bringing the arm across the chest, and O'Brien's test can be helpful. A cluster combining the ACJ resisted extension test, cross-body adduction, and O'Brien's tests resulted in an 80.5% post-test probability when all three were positive according to the source.
Again, the cluster makes it much more likely.
Indeed. The Paxinos test, which involves applying pressure directly to the AC joint, and the ACJ distraction test for vertical instability are also noted as part of the assessment.
The source also flags that pain from the cervical spine, the neck, can mimic shoulder issues. How do you try and tease that apart during the examination?
That's a crucial distinction to make, absolutely. The source mentions the Sperling's test, which involves extending and rotating the neck to provoke cervical spine pain, as a helpful test. If that reproduces their specific pain, it points towards the neck.
Makes sense.
Additionally, the observation that shoulder abduction relieves the patient's pain, just lifting the arm up, takes the pressure off the nerve root, maybe is noted as a diagnostic cluster point, strongly suggesting the pain is originating from the neck rather than the shoulder itself.
That's a neat trick, seeing if lifting the arm helps. And finally, problems with scapular movement, winging scapula and things like that.
Yes, scapular dyskinesis, or abnormal movement of the shoulder blade, can be assessed with tests like the scapular assistance test. Here, the examiner manually helps guide the scapula's movement during arm elevation.
Physically helping the shoulder blade move correctly.
Exactly. If this assistance reduces the patient's impingement-like symptoms, it suggests the abnormal scapular motion might be contributing significantly to the problem. The wall test can also accentuate medial winging of the scapula, highlighting serratus anterior weakness, perhaps from a long thoracic nerve issue. EMG testing can confirm nerve involvement, but doesn't predict prognosis or severity according to the source.
It's clear that special tests are powerful not because of any single test's perfection, but because of how they contribute unique pieces of information that, when clustered with other findings from history and exam, increase your diagnostic confidence significantly.
Absolutely. The move is from relying on a single positive test to interpreting patterns and combinations across the pillars.
So we've got history, exams, special tests. The fourth pillar is investigations, primarily radiology or imaging. How do these visual data points fit into building that overall diagnostic cluster? Are they the final confirmation?
Imaging is the fourth pillar, and its role, as the source clearly states, is to provide additional information that can support, or importantly, refute the clinical suspicion that you've developed from the first three pillars.
Support or refute, not dictate.
Precisely. It is intended to complement the clinical assessment, not to replace it as the primary diagnostic tool. You shouldn't just order a scan without a clear question in mind based on your clinical assessment.
So you're using imaging to confirm or refine, perhaps check for unexpected things, not just as a fishing expedition.
Exactly. It should be targeted based on your clinical findings. Plain radiography, or X-rays, are the standard initial views, typically an AP view, a lateral or outlet view to see the acromial shape, and an axillary view.
The basic views.
Yes. They are excellent for visualizing bony abnormalities, fractures, bone spurs, osteophytes associated with arthritis, cysts, or sclerosis, hardening of bone. The lateral view is specifically useful for assessing acromial morphology, the shape of the bone overlying the rotator cuff, which is relevant in subacromial impingement discussions. The source notes that in cases of rotator cuff arthropathy, that's severe cuff tear, combined with arthritis, you can see significant narrowing or even obliteration of the subacromial space alongside changes in the glenohumeral joint itself. Calcific tendinitis, calcium deposits within the rotator cuff tendons, is also usually clearly visible on X-ray.
What about ultrasound? It seems like it's becoming more prevalent. You see it used in clinics more often.
Ultrasound is a valuable tool because it's fast, portable, and allows for dynamic examination. You can see how structures move as the patient moves their arm, which you can't do with MRI or X-ray.
Real-time assessment.
Exactly. It's particularly useful for assessing the biceps tendon, identifying tears, tenosynovitis, inflammation of the sheath, or subluxation popping out of its groove. The source highlights that biceps subluxation is often associated with a subscapularis tear, so finding one points you to look for the other.
A linked injury.
Often, yes. A complete biceps tear is also visually obvious with the characteristic Popeye sign, where the muscle bunches up, which ultrasound can confirm. Ultrasound is also effective for assessing rotator cuff tears, helping to determine if they are full or partial thickness, and evaluating tendon retraction and tear size.
What are its limitations compared to, say, MRI? Is it as good for everything?
Not quite. The source mentions ultrasound is less useful for visualizing intra-articular structures, like the labrum, or for diagnosing adhesive capsulitis. However, for focused questions like, is the biceps tendon subluxing, or is there a full-thickness cuff tear? It can be as accurate as MRI in experienced hands.
So it depends on the question you're asking.
Precisely. It's considered a valuable adjunct to the clinical exam, especially in the clinic setting, and is often used to guide injections, like subcoracoid injections for impingement, with precision.
MRI feels like the gold standard for soft tissues for many people. How does the source position it?
MRI does provide a more global assessment of the soft tissue surrounding the shoulder, that's true. Gives a broader picture. The source strongly recommends MR arthrography, where contrast dye is injected into the joint space before the MRI scan for specific indications.
Injecting dye first.
Yes, particularly for suspected SLAP tears. The dye helps visualize if a tear undercuts the superior labrum by seeping into the gap. However, the source adds a caution. Interpreting MR arthrography for SLA tears requires expertise, as normal anatomical variations or insufficient joint distension with the dye can lead to false positives or negatives.
So it needs careful interpretation.
Very much so. MR arthrography is also considered significantly more accurate than plain MRI for assessing instability because the dye distends the joint, providing much clearer views of cartilage lesions, labral tears, ligaments, and the rotator interval, the gap between tendons at the front.
So the contrast makes those fine internal details much easier to see, especially for things inside the joint, like the labrum and ligaments.
Exactly.
Yeah.
Plain MRI without contrast is still very useful for a range of issues. It's excellent for visualizing rotator cuff tears, especially assessing the degree of fatty infiltration in the muscles and overall atrophy, which are critical factors for surgical planning and prognosis.
How much the muscle is wasted away.
Yes, and how much fat has replaced it. MRI can also trace the course of nerves, identify cysts or soft tissue tumors, and is valuable for assessing the shoulder after instability surgery if there are symptoms suggestive of recurrence.
And CT scans, when are those most helpful? They use x-rays too, don't they?
They do, but CT scans use X-ray technology to create detailed cross-sectional images and 3D reconstructions. They are best when assessing bone. They are the go-to for evaluating complex fractures and dislocations where you need a precise 3D understanding of the bone anatomy.
Seeing the bone in 3 dimensions.
Exactly. CT is also essential for preoperative planning in arthritis cases, particularly for glenohumeral or rotator cuff arthropathy, as it allows surgeons to quantify the amount of bone loss, especially from the glenoid socket, which is crucial for deciding the type of joint replacement or reconstruction needed. For instability, a CT arthrogram with dye can be used as an alternative to MR arthrogram to visualize cartilage and labral tears, and CT is excellent for identifying and measuring bony Bankart lesions, bone loss from the glenoid rim, or Hill-Sachs defects, and an indentation fracture on the humeral head. These bone injuries are common with dislocations.
Measuring the bone damage accurately.
Yes. The source also highlights CT's use in assessing coracoid impingement, where it's used to measure the coracohumeral distance, the space between the coracoid bone and the humerus. A distance less than 11 mm is suggestive, and specifically for symptomatic coracoid impingement, less than 4 mm is noted as relevant. They also mention the coracoid index measurement, where an index greater than 8 mm extending lateral to the glenoid tangent can be a factor, particularly when evaluating subscapularis pathology.
So CT is your friend when bone detail is paramount, or when you need precise measurements of bony structures and spaces.
Absolutely. Finally, the source briefly mentions nuclear medicine, specifically technetium 99 meta MDP bone scintigraphy, or a bone scan. This technique assesses areas of increased osteoblastic activity, essentially highlighting areas where bone is actively remodeling or reacting.
Hot spots.
Exactly, which can occur with tumors, infections, fractures, or arthritis. Paget's disease. It's sensitive. It will often show something is happening, but critically, it's not specific. It tells you there's abnormal activity, but not necessarily what is causing it.
Like detecting that there's heat, but not whether it's a fireplace or a wildfire.
That's a very good analogy, yes.
Yeah.
It needs to be interpreted within the broader clinical context provided by the other pillars.
Okay. We've walked through the 4 pillars: history, exam, special tests, and investigations. It's abundantly clear the source emphasizes that none of these stand alone. How does putting it all together, using this cluster approach, actually work for specific conditions? The source gives some specific examples to illustrate this, doesn't it?
It does. Let's take adhesive capsulitis, or frozen shoulder, as a prime example from the source. The classic history is often a middle-aged individual, particularly women around 50, often with comorbidities like diabetes, which, as we noted, increases the risk significantly, or thyroid issues.
That specific patient profile again?
Yes, the onset is typically insidious, meaning it comes on gradually over months, leading to progressive pain and a marked loss of range of motion that significantly impacts daily activities like reaching overhead, behind their back, or sleeping.
Yeah.
Very disabling.
So the history immediately gives you a profile and a pattern of symptom progression, that gradual tightening.
Precisely. Then you move to the physical examination, and this is where you confirm the key finding. True stiffness. This is demonstrated by a severe restriction in both active and passive range of motion, often with a characteristic firm end feel when you try to move the joint passively.
Hits a definite stop.
Yes. You'll observe that any apparent movement is largely coming from the scapula rotating on the chest wall, not from the glenohumeral joint itself, as we discussed.
They're compensating.
Exactly. Imaging, typically plain X-rays, is usually normal in adhesive capsulitis, although there might be incidental findings like mild AC joint arthrosis, as noted in the case example, but nothing to explain the profound stiffness.
And that normal imaging is actually part of the cluster. It rules other things out.
It is, absolutely. The source notes that the diagnostic cluster for adhesive capsulitis relies on the characteristic history, age, comorbidities, insidious onset, progressive loss of function, combined with the hallmark physical exam finding of true global stiffness, restricted active and passive ROM. The imaging findings, being largely normal, help to rule out other potential causes that could mimic some of these symptoms, such as advanced glenohumeral arthritis or perhaps a missed posterior dislocation, which would be clearly visible on imaging. So it's the combination of these specific elements, history profile, true stiffness on exam, and essentially normal imaging that forms the powerful diagnostic cluster for adhesive capsulitis.
That's a very clear illustration. How about internal impingement, which the source links specifically to overhead athletes, like throwers?
Internal impingement is a great example of a cluster that requires a specific context. The history typically involves a young throwing or overhead athlete who develops insidious onset of deep posterior shoulder pain in their dominant arm, not usually anterior pain.
Pain at the back of the shoulder.
Yes. The pain is usually aggravated by the specific motion of throwing, particularly the late cocking phase, when the arm is right back. They often report decreased performance or velocity. They just can't throw as hard.
Loss of power.
Exactly. On physical examination, you might find tenderness on palpation of the posterior joint line. While throwers often have adaptive changes like increased external rotation and decreased internal rotation in their throwing arm, the source clarifies these are normal adaptations and not diagnostic on their own. You might also note a protracted scapula, as mentioned before.
So the history gives you the context and the pain location. The exam adds some objective findings, but requires careful interpretation, knowing what's normal adaptation versus pathology.
Exactly right. Then you add special tests. The relocation test and the posterior impingement sign are key tests here. If they reproduce the patient's specific posterior shoulder pain, that's a significant piece of the cluster.
Reproducing that specific pain.
Crucial. Imaging adds the visual component. Plain X-rays or CT scans might reveal bony adaptations like cystic lesions or posterior glenoid osteophytes, bone spurs, sometimes referred to as a thrower's exostosis. MRI is crucial for assessing the soft tissues, often showing undersurface rotator cuff tears or posterior-superior labral pathology, right where the impingement occurs.
So for internal impingement, the cluster is built from that specific history in an overhead athlete, combined with posterior pain reproduction on specific tests and potentially characteristic bony or soft tissue findings on imaging in that posterior superior area.
Precisely. And the source wisely notes that because some of the exam or imaging findings, like increased external rotation or maybe minor labral fraying, can be present in asymptomatic throwers, the diagnosis requires a synopsis of multiple signs and symptoms. The entire cluster must fit together rather than relying on any single isolated finding. It's the sum that's diagnostic.
Makes sense. It's about the whole pattern. Let's look at one more example. Pectoralis major rupture. The source gives a clear case for this one, often in younger active men.
Yes, this often presents with a very distinct history. Typically a young male engaged in manual labor or athletics, experiencing sudden acute pain and often hearing or feeling a pop during a forceful activity like bench pressing or tackling.
A very specific event.
Usually, yes. The history provides the clear mechanism and the immediate dramatic symptom. On physical examination, the findings are often visually obvious. Loss of the normal contour of the anterior axillary fold. The front part of the armpit looks different, less defined. The characteristic drop nipple sign, where the nipple on the affected side sits lower than the other.
You can actually see the nipples lower.
Yes, quite noticeably sometimes. And often significant bruising, ecchymosis, and swelling in the chest wall and upper arm.
Those visual cues sound very specific, almost unmistakable if you know what to look for.
They are, if you consider them together. Special tests like resisted adduction, pushing the arm across the chest against resistance, or passive abduction, lifting the arm outwards, can accentuate the deformity where the muscle should be and reproduce the pain. Imaging, most commonly MRI, is used to confirm a full thickness tear and is vital for planning surgical repair. Although the source mentions that even in chronic cases, a confident clinical diagnosis can often be made based on the history and physical exam findings alone, with imaging used more for confirmation and planning the specifics of the surgery.
And the source points out that this is an injury often initially misdiagnosed, maybe put down to a muscle strain.
It does, which again underscores the importance of recognizing this specific pattern and knowing the key historical and physical exam findings that form its diagnostic cluster. The dramatic history of sudden pain and pop during forceful activity, combined with the specific visual findings, like the change in the axillary fold, the dropped nipple sign, and bruising, forms a strong cluster that should immediately raise suspicion for a pectoralis major rupture, which imaging can then confirm for surgical planning.
These examples really powerfully illustrate the core message, don't they? Relying on just one piece of information, whether it's a patient self-diagnosing from the internet, a clinician ordering a scan too early without a clear clinical picture, or focusing on a single positive test result is just insufficient and really prone to error.
That is precisely the central thesis of the source material. It makes the case that an accurate diagnosis is achieved not by finding a single smoking gun, but by intelligently combining information from all four pillars: the patient's detailed history, the objective findings from the physical exam, the results of carefully selected and interpreted special tests, and targeted imaging investigations.
Weaving it all together.
Yes, recognizing diagnostic clusters from this synthesis leads to a far more precise and complete understanding of the patient's specific health problem.
And it's that precise understanding that allows for effective treatment, bringing us back to the beginning.
Exactly. It is the non-negotiable first step that determines what treatment is appropriate, when it should be delivered, and what the patient can reasonably expect. This framework and its emphasis on the diagnostic cluster approach are highly relevant for any professional operating in or around healthcare.
Not just the surgeons or physios.
No, absolutely not. Whether you are a clinician involved in developing medical devices, working in insurance where diagnostic accuracy impacts claims and pathways, or perhaps in a corporate role managing employee health and well-being, understanding that accurate diagnosis is complex and requires this multifaceted approach is key. It directly impacts treatment outcomes, recovery times, resource allocation, and ultimately the overall value delivered by the healthcare system. Investing effort and rigor at the diagnostic stage, that value on the front end, pays dividends down the line.
This deep dive has truly peeled back the layers on what goes into diagnosing seemingly common problems like shoulder pain, demonstrating that it's far more nuanced than just getting a scan. We've explored the underlying rationale, the critical importance of diagnosis as the foundation, the four essential pillars of information, and how bringing them together into diagnostic clusters provides a far more reliable path forward, all drawn directly from our source material. As we wrap up, here's a final thought to ponder, something the source touches on by including patient-determined factors in the framework. Given the complexity of gathering and synthesizing information from history, exam, tests, and imaging into a diagnostic cluster,
How can we best empower patients who are living with the problem every day to contribute meaningfully and accurately to their diagnostic journey beyond simply reporting their symptoms? What does true patient partnership look like in this sophisticated multi-pillar diagnostic process? Something to think about. If you found this deep dive valuable, please do consider rating and sharing the show with a colleague.
Thank you for joining us for this deep dive into the art and science of shoulder diagnosis.
Thank you. It's been a pleasure discussing it.